let's start with our new TOG article, that is endometriosis and subfertility. I'm Dr. Preeti Poghe, the mentor and owner of Mrcog. So this new TOG article that is released just now in January 2024 has an article about this endometriosis and its effect on subfertility. So we'll just go through the highlights of this TOG article, and it can also be there for just revision before you go to the exam so that you don't lose time in reading the TOG article. So basically, this TOG article tells you about the prevalence of endometriosis in women of reproductive age. So the prevalence in UK is approximately 10%. In women with subfertility, it increases to 25 to 50%. Okay. So endometriosis can have a varied clinical presentation, which we know, which we see so many patients with fertility and endometriosis both in our clinics. So endometriosis may present either with pelvic pain or they may come with bowel dysfunction, or it may just be an incidental finding which we do on sonography. So endometriosis does anatomical distortion. It does affect your uterus, the fallopian tubes, and the ovaries, right? So it is associated with inflammation and pelvic distortion. It is understandable how severe endometriosis with associated tubal damage may impair the egg capture and the transport, right? So evidence has linked that the degree of endometriosis to the corresponding decline in conception rates. We know that it may affect the tubes, it may affect the ovaries, the oocyte quality, everything. So up to 30% of women with endometriosis have tubal pathology. So this is important. When a patient has got endometriosis, there are 30% chances that this patient will have a tubal pathology. Either there are obstructions or adhesions or hydrosalpinx. However, even when women with mild endometriosis, they have lower fertility rates. So suggesting that basically this causes some mechanical barrier to pregnancy, which cannot be seen in the whole picture. So what else can the endometriosis cause? So basically it can cause dyspareunia, it may affect the ovarian reserve, pelvic surgery might be there, already done by the patient, so which can also cause subfertility. Endometrial receptivity is affected, there is effect on eggs, and also there is anatomical distortion because of endometriosis. Endometriomas, they are found in 17 to 44% of women with endometriosis, and almost 1/3 of those affected, they will have bilateral cysts. Okay, so 1/3, that is a big number. So around 35% patients will have bilateral cysts. There is growing evidence that endometriomas have a detrimental effect on the ovarian function, and not only that they occupy the space in the ovary, but also they cause oxidative stress reaction, which is a very important factor for subfertility, isn't it? So they actually not only affect by taking the space in the ovary, but also cause oxidative stress reaction in a healthy ovary, which may lead to fibrosis, loss of cortical stroma, smooth muscle cell metaplasia, impaired vascularization, right? And at a later stage, it may reduce the follicular maturation and atresia in early follicles. Okay, so basically initially it may cause inflammation and all, and later on it may also reduce the maturation of the follicles and cause atresia in the early follicles. Endometriomas can also be significant cause of dyspareunia. If they are very big, of course, they can cause dyspareunia, which can lead to impairment of the sexual function. Of course, it leads to infertility. Endometriosis and the oocyte embryos using the donor oocyte. They have studied this. If they use a donor oocyte model to assess the impact of endometriosis on the oocyte quality, they have shown that if they take oocyte from a patient, from a donor who has endometriosis, and they implant it in try to transfer it in a patient without endometriosis, then there is reduced fertility rate, there is reduced implantation. Okay, so because the implantation rate is less in the patient without endometriosis, if you take oocyte from a patient with endometriosis, it suggests that endometriosis affects the oocyte quality also. Endometriomas, which are larger than 3 centimeters, they were associated with increased number of immature oocytes. When oocytes from women with endometriosis have been examined under electron microscope, we see that these oocytes, they have abnormal mitochondrial structure, and they also have reduced mitochondrial mass. So that means they affect the oocyte and affect the mitochondrial mass of the oocytes in patients with endometriosis. And no studies have demonstrated a higher rate of aneuploidy. There is no congenital anomalies or aneuploidy in patients with endometriosis. So authors concluded that there may be either minimal or no effect on the oocyte quality on the IVF outcomes, because ultimately endometriosis patients, they do have almost the same rate as that of all the other patients. So there is no effect of this endometriosis that will affect the oocyte IVF outcomes at the end in women with endometriosis, and that the reduced live birth rate may be because of the endometrial receptivity. So after they did a study, which is there in the TOG article, of course, you need not go through the whole study, but after that, there's a conclusion by the authors that uh, the oocyte quality doesn't affect the IVF outcomes. Of course, there's less implantation rates and everything, but most of the time, this study has said that though it affects the oocyte quality, the major problem with the IVF success is because of the impaired endometrial receptivity in a patient with endometriosis. Endometriosis is a chronic inflammatory condition that results in systemic and local inflammatory changes. There is an increase in the cytokines and chemokines involved with inflammation, and also there are numerous immune cells macrophages, helper cells, natural killer cells, all of them are dysregulated. Okay. Also, it is also associated with reduced progesterone sensitivity in the endometrium, which in turn leads to pro-inflammatory, pro-proliferative imbalance in the endometrial environment. So it all leads to a pro-inflammatory environment, which of course affects the implantation rate. It is also important to note that the euploid embryo transfers were conducted in medicated FETs, right? So they did the embryo transfers, the euploid embryo transfers, and they have seen that because of these pro-inflammatory factors that are there during the endometriosis, in a patient with endometriosis during the fresh cycle. So what happens is when you suppress them in a frozen embryo transfer cycle, when you suppress them with your hormones, then exogenous hormones that we give, right? So we suppress it by giving an agonist and then later on giving the exogenous hormones. So that helps to suppress the endometrial alterations that have occurred because of endometriosis. The pro-inflammatory factors get suppressed and improves the IVF success rate. There is this Enzian scoring system. It is a descriptive surgical scoring system and can be applied to preoperative imaging assessment, which has proven value in preoperative prediction of laparoscopic operating time, how much time will be required for the surgery. So that will give us an idea beforehand. So that is the score that is called as Enzian score. Okay. There are few more scores about fertility. A scoring system which specifically is developed for women in whom fertility is the priority, and though they have this endometriosis, it is called as EFI, that is endometriosis fertility index. So it is a 10-point scoring system, and it is grouped into different categories. There is this table which will come up after a couple of slides. So basically, this EFI scoring system, it can accurately estimate preoperatively based on clinical and ultrasound data, how much is the pregnancy rate, or what will be the outcome, how much is the success rate of this patient. Okay, so basically depending upon the clinical and the surgical data. As such, the EFI, along with other factors like patient symptoms, age, history of previous surgery, if there are any other infertility factor, how much is the ovarian reserve, everything. All of this will help us in making a decision whether this patient should go for a surgery, whether this patient should go for an IVF, and how much will be the what will be the outcome, how much will be the success. So it'll just give us an idea beforehand. So if you have to do a medical management of endometrioma or a chocolate cyst, what do you do? So to achieve a spontaneous conception, what do? We do give contraceptives, isn't it? So to suppress the normal hormone function, we do give contraceptives. So Eshre has said that it is the ovarian suppression that should not be prescribed to improve the fertility. If it is to be given to improve the fertility, then it should not be given to improve the fertility in patients related to endometriosis. So the most recent ESHRE guideline says that there is evidence for no harm rather than evidence of benefit. So therefore, post-operative medical therapy should not be prescribed. After the surgery, when we give this medical therapy to the patient, it should not be prescribed with the intention of improving the fertility. It may not improve the fertility, okay, but rather it should be reserved. This post-operative therapy that we give, no, after the surgeries of patients with endometriosis or a chocolate cyst, after that we give suppressive therapy. So basically it should be given for patients with for pain management, because that is not going to help to improve the subfertility. Okay. Surgical management of minimal or mild endometriosis for spontaneous conception. So they say that the symptomatic benefit in a patient with mild or moderate, minimal or mild endometriosis with surgery, the symptomatic benefit is, of course, controversial, but they say that Ishre recommends that the laparoscopy could be offered as a treatment for endometriosis related fertility for early stage endometriosis, as it improves the success rate of improves the rate of ongoing pregnancy. It means that you may or may not have improvement in the symptoms, because generally the early stage endometriosis patients may not have much of the symptoms, but it does improve the fertility rate, okay, when you do surgery in a minimal or mild endometriosis patient. When you do surgery for a moderate or severe patient, severe endometriosis patient, therein, of course, it should be done to improve the symptoms, because these patients, they may have severe symptoms. Approximately 20% of women with endometriosis have deep component to their disease. So the benefit of excision of the surgery for symptomatic relief in women with severe endometriosis have been shown to last up to, when you do a surgery for this severe endometriosis patient, it lasts for up to 4 years. Post-surgery, the benefits of fertility alone are, whether it is going to benefit the surgery or not, it is less clear. So this is the EFI score that we were talking about. So basically, they have shown us that this endometriosis fertility index, it has got a least function left score at here above, and below there is this endometriosis fertility index. So on the left hand side, you can see that there is whole history like age of the patient, then also about the previous surgeries, if there are any, all the history points, they'll come on the left hand side. On the right hand side, you will see that if they have given us the LF score, they have given the whole score, like also depending upon the AFS endometriosis score. So you basically, it is the history score plus the surgical score that will give the EFI score, and how much is the rate. So if the values are more than it is a 10-point score that we have seen, right? So what is the EFI score? If you get a good EFI score, then it gives you an understanding whether your IVF or your ART is going to be successful or not. Okay. Pregnancy rates following excision of deep endometriosis with or without bowel involvement. They have given you the rates of that. So if there is no bowel involvement, of course, the success rate is more, that is 50%. If there is bowel involvement, then it is 20 to 30%. ASHRAE guidance is that surgery for deep endometriosis does not definitely improve fertility, but may be an option in symptomatic women wishing to conceive. So a meta-analysis of studies into the impact of cystectomy after you do a cystectomy for endometrioma, it has been shown that it reduces the AMH, 30% reduction in the AMH, but there is not much effect on the AFC. Okay, so excision of larger endometriomas, that is 5 to 7 centimeters, and bilateral endometriomas are causing more, they are more worse as compared to the single site. So they are going to affect the ovarian reserve. The risk of premature ovarian insufficiency after bilateral cystectomy is 2.4. That is very high. So when you do cystectomy for both bilateral endometriomas, your risk of having premature ovarian insufficiency is going to be increased, and the risk is around 2.4%. Okay, and that is why they say that cystectomy should be done after you are done with your fertility part. Okay, so cystectomy for endometriosis would also appear to have greater impact on ovarian reserve compared with cystectomy for other non-malignant indications. So when you do it for other things, it is still okay, but when you do it for fertility, of course, you're affecting the AMH and the ovarian reserve. So ASHRAE recommends that where surgery is undertaken, cystectomy should be performed to reduce the risk of recurrence. Okay, and ultrasound guided sclerotherapy, they are saying it is better as compared to cystectomy. When you do it for a patient with minimal endometriosis or mild endometriosis, it appears to have no impact on clinical pregnancy rates or live birth rates. So the presence of moderate or severe endometriosis, of course, it severely affects the live birth rate and causes a lot of subfertility. So we have seen this slide, sorry. Intrauterine insemination, that is IUI, that we do in our clinics, it has been considered to be affected when you have a patient with severe or this moderate or severe endometriosis, of course. But they have also tried, when you do it, it also it should be tried in patient with mild or minimal endometriosis. So after they have tried to conceive for 1 year, or in those with same-sex relationships, so you can consider IUI rather than directly going for IVF. So IUI may be useful in mild or minimal endometriosis, though with a little lesser rates of success. It has been shown that the presence of mild or moderate endometriosis reduces the success of IUI even in context to the normal tubes. So even if the patient has normal tubes and the patient has ovaries, endometriosis, it is going to affect the success rate. So you have to, beforehand only, you have to counsel the patient regarding that. The success of IUI in women when the patient is more than 40 years is low, because the live birth rate per cycle is in itself is less than 4%. And IVF should be considered for these patients who are more than 40 years of age and having endometriosis. Women with endometriosis, they have a lower number of oocytes collected despite a similar AMH. So if you have two patients, with one is having AMH of say 1 and another one is having endometriosis with AMH of 1, you will still get lower number of oocytes in patients with endometriosis. Okay. So when undergoing IVF, women with severe endometriosis may require almost double the dose of gonadotropin. So you have to be counseling this to the patients, right? And also still achieve lesser number of oocytes. In patients with endometriosis, if it is more than 30 mm, then endometrioma size was the most influential contributor to the number of oocytes collected. So importantly, you have to remember that cystectomy is associated with poorer response to stimulation and the greater risk of cancellation compared with no surgery. So basically try to go for no surgery, because it is later when you do a surgery or cystectomy, it is going to affect the fertility rate. This is a very nice table that is there. So basically they'll tell you what to do in a patient with endometriosis. So if you want to go for a medical therapy in a patient with mild or minimal endometriosis, it is not going to improve the conception. In a moderate one, it no improvement to natural conception, but post-operative suppression prior to ART used to prevent the symptom recurrence. And in endometriomas, dynogest suppression, they say that dynogest is better, and it is going to not affect the AMH more, so that it has less impact on AMH. When you go for a surgery in a patient with mild or minimal endometriosis, we see that it is increases the chances of natural conception and could be considered a good prognosis for this patient. Uh, Again, in moderate, severe endometriosis patient, we see that if you go for a surgery, it is going to improve the symptoms, but it may or may not improve the IVF success rates, right? Or the fertility rate. So consider in symptomatic women with previous failed IVF. So in those cases, you can go for surgery there. And when a patient has got endometrioma, cystectomy carries the risk of reducing the ovarian reserve. Cystectomy has the advantage of preventing recurrence. So routine cystectomy does not increase the live birth. Consider surgery if access to the ovary for oocyte retrieval is not possible. So if you can't reach there, then of course you have to go for a surgery. Again, you have a patient with mild or minimal endometriosis. Okay, sorry. And you're going for assisted reproduction, then it does not reduce the success rate of ART, the mild or minimal endometriosis. But of course, in a severe or moderate endometriosis, it is going to reduce the number of eggs. It is going to reduce the success rate of IVF also. When you have an endometrioma more than 3 centimeters or 30 mm, then there is significant negative effect on the number of oocytes collected. And if you go for a cystectomy, again, there is going to be risk of poor ovarian response to the stimulation. More number of gonadotropins, dose of gonadotropins may be required. If there is a patient who has got endometriosis, now she has to go for a surgery because of the severe pain and everything, or she is trying for pregnancy. In those cases, fertility preservation is always better. So basically, try to remember this, that the cumulative live birth rate was significantly lower in women less than 35 years of age who had surgery prior to the fertility preservation, FP is fertility preservation. Whereas in women over 35, there was no effect of surgery on cumulative live birth rate. So the author recommends that surgery should be done after fertility preservation in young women, and that an individual approach should be considered in women over 35 years of age, because after 35 years of age, there is not much effect. So if a woman opts for fertility preservation after counseling, she should be aware that there are two main factors. One is the impacting the live birth rates, that are the number of oocytes and that needs to be vitrified, and second is the age, of course. So it is recommended that if a woman is less than 35 years of age, she should preserve at least 10 to 15 oocytes to achieve a live birth rate between 40 to 70%. So again, this is important. Okay, so the patient should generally be less than 35 years of age and should have at least 10 to 15 oocytes cryopreserved to convert it into a pregnancy. A recent RCT comparing perioperative ovarian suppression with GnRH agonist or Dynogest found that ovarian reserve was as measured by AMH significantly better preserved in Dynogest cohort. So when you give either Lupride or any other agonist uh, for ovarian suppression and Dynogest, so it has been seen that Dynogest was better, right? It may contribute to the efforts to minimize the negative effect of surgery, especially for women with bilateral endometriomas. So avoid ovarian cystectomy in patients who are going for fertility preservation. Prior to the ovarian stimulation, you should avoid cystectomy unless it is indicated for pain or to access the ovary for the oocyte retrieval. Consider FP for women requiring surgery, especially in women with bilateral endometriomas and in stage 3 or 4 disease. Okay. So if ovarian reserve is low, this advice must be tailored to the women. Right? So you have to consider this fertility preservation for patients who are having this severe disease. Following a surgery, continue medical suppression until the patient is ready to conceive. So that brings you to the end of the TOG article. I hope that this video will help you during your revisions and will also be useful to revise the TOG article even when you're traveling or not reading yourself. Thank you very much.